Hi students, this is a brief lecture covering the content for a health assessment of the heart and neck vessels in the peripheral vascular system. You should definitely review the anatomy and physiology in the beginning of both of the chapters you're reading for this week. Note that the location of the heart is in the mid-chest, with a greater portion to the left of the sternum than to the right. And this image from your chapter illustrates the location of the heart in relation to the lungs and the diaphragm. It also notes the intercostal spaces, which are important landmarks for auscultating and palpating. An important concept to remember is that the base of the heart is at the top, found at the second intercostal space, and the apex of the heart is at the bottom, found at the fifth intercostal space. This is important for you to know because in the respiratory lecture, you learned that the apex of the lungs was at the top and the base of the lungs was at the bottom. It's the opposite in terms of cardiac landmarks. So make sure that you know this. The reason is because the top of the heart is wider and the bottom is more narrow. So the base of the heart is found at the second intercostal space, and the point of maximum impulse, which is known as the PMI, is the area where the apical pulse is the most prominent and is the best location to auscultate an apical pulse. This is generally located at the fifth intercostal space at the junction with the mid-clavicular line. In terms of the anatomy of the great vessels, the arterial great vessels include the carotids, the aorta, and the pulmonary vein. The venous great vessels include the jugulars, the superior and inferior vena cava, and the pulmonary arteries. And the heart chambers are the two atria and the two ventricles with a septum in between. The great vessels originate from the base, the top of the heart, then turn towards the body part that they supply. The carotid arteries run parallel to the trachea, as you can see in the image, and lie in the depression between the trachea and the sternocleidomastoid muscle. When you are demonstrating assessment of the carotid arteries in lab, you may be asked what your landmarks are that you use to locate the arteries. The trachea and the sternocleidomastoid are landmarks that you would use because the carotid arteries run between those two landmarks. Brief review of the structure of the heart. There are four valves, major valves in the heart. There are the atrioventricular valves, or the AV valves, which separate the atria from the ventricles, and those are known as the tricuspid valve and the mitral valve. There are two semilunar valves, which separate the ventricles from the great vessels, and those are known as the pulmonic and the aortic valve. Moving on to the peripheral vascular system. The peripheral vascular system consists of the arterial system and the venous system. The arterial system includes arterial arteries, arterioles, which then end at the capillary bed. The capillary bed then goes back by venules into veins and back into the right side of the heart. The arteries are have thicker layers to their you should review the conduction system of the heart. Remember that the pulse originates at the SA node, and that is sort of considered the automatic pacemaker of the heart. The conduction is through interatrial pathways, through the AV junction, the bundle of His, and finally the Purkinje fibers. Remember that the heart is a double pump system with two major divisions. The right side of the heart pumps the pulmonary circulation, and the left side of the heart pumps the systemic circulation. The cardiac cycle consists of systole and diastole. The first heart sound, which is known as S1, which is the beginning of ventricular systole. Systole is the squeezing or the contracting of the heart, and the first heart sound is known as lub. Lub, or S1, is caused by the closure of the mitral and tricuspid valves. The second heart sound is the end of systole and the beginning of diastole. Diastole is the relaxation phase of the cardiac cycle. The second heart sound, or dub, S2, is the closing of the pulmonic and aortic valves. And the second heart sound is what causes the pulse that we palpate in the extremities. Please review this cardiac cycle on page 456 to 457 in your textbook. Remember that in performing a health assessment on the cardiovascular system, there are certain times when an urgent assessment is necessary. Cardiac emergencies necessitate rapid assessment and intervention, and certainly symptoms that would require an urgent assessment would include chest pain, especially if it's accompanied by shortness of breath and an abnormal blood pressure and or inadequate perfusion. And your assessment should be focused on the physical examination of the cardiac and respiratory systems. If you determine while you're doing your subjective assessment that the patient requires an urgent assessment, you need to jump to an urgent objective assessment and intervene quickly. An urgent assessment with the peripheral vascular system would include a limb-threatening situation, such as no blood flow to an extremity. That would be manifested by pain, numbness, coolness, or poor color. A deep vein thrombosis is an urgent situation related to the peripheral vascular system. Deep vein thrombosis manifests with pain, edema, and warmth over the extremity, generally the calf. A pulmonary embolism is a life-threatening emergency caused by thrombus that has moved and obstructed a major vessel in the lungs. The signs of a pulmonary embolism is acute dyspnea, chest pain, tachycardia, diaphoresis, and anxiety. These would require urgent assessments. When you are completing a subjective assessment for the cardiac and peripheral vascular system, you include a risk factor assessment as well as getting basic demographic and biographical information. As we do with all body systems, we want to know about the patient's past medical history. There can be some conditions that are not just necessarily associated with the body system that we are assessing, but where there could be implications. For example, thyroid disease can have implications for the cardiac system. We also want to know what medications the patients are on. Again, medications that are used to treat one problem can have an impact on another body system. Certainly, asthma medications can have cardiac side effects, and we know that other medications can as well. We want to make sure we're assessing for family history, especially family history of cardiac disorders when we are doing a cardiac assessment. We want to assess for personal behaviors and lifestyle behaviors that can impact the cardiovascular system. Your textbook goes over these in detail. As we know, while we are completing a subjective assessment, it is an important time for us to include risk reduction and health promotion, especially when patients tell us that they smoke. Instead of just taking down that information, it's important for us to begin some risk reduction counseling by letting patients know that particular lifestyle habit has health implications that could be devastating for them. Again, when we ask about diet, if we assess that the patient has a diet that's high in fat and cholesterol, we want to explain what the impacts of that are on their overall health. Some common cardiovascular symptoms that we see in patients include chest pain, dyspnea, orthopnea, which is difficulty breathing in different positions, paroxysmal nocturnal dyspnea, which is difficulty breathing at night, cough, diaphoresis, fatigue, edema, nocturia, voiding at night, and palpitations. Common peripheral vascular symptoms include pain, numbness or tingling of the extremities, cramping, skin changes, edema, and decreased functional ability. Remember that when we are talking about health assessment, there are considerations that we need to take into in terms of the age of our patients and our aging population. As the human body ages, there are further problems and the body systems start to decline. So there are definitely findings consistent with older populations that we wouldn't necessarily see in the young population, just as there are considerations for children. They have very young organ systems and they haven't lived long enough to develop chronic disease. So the findings are very different. Also, based on their size and their age, the anatomical positions of various organs can be different than what is found in adults. Common changes that occur as patients age include decreased activity tolerance, syncope or fainting, arrhythmias, or heart failure. Again, the heart is an organ, it's a pump, and pumps fail. So over time, the pump works so well for us for our whole lives, but once you get into the 8th, 9th, or 10th decade of life, you can see that a pump may start to lose its ability to function. Arterial disease is common and frequently underdiagnosed. Systolic hypertension increases with age, and decreased activity that comes with age leads to venous stasis, which can lead to clot development and decreased joint mobility. Your textbook, each of the chapters that you wrote to read this week, 17 and 18, include sections on cultural considerations related to the CV system, especially which ethnic groups we see cardiac disease in more commonly. It's important for you to become familiar with the cultural variations associated with the various body systems. Moving on to objective assessment of the patient for cardiovascular. You want to think about what the common techniques are that we use and what equipment is necessary. What equipment comes to mind? There isn't that much equipment that you need, but you definitely need a stethoscope. You probably need a watch with a second hand, and depending on what techniques you're going to be using, you may need more equipment than that. Certainly, we use our hands and our eyes as important tools in assessment. We always begin with inspection, and then we move on to palpation and auscultation. Again, I told you that I'm not going to have you accountable for percussion at this level. I do not think it's a skill that is used often by the bedside nurse. The objective data that you are going to obtain is going to include inspection of the chest and the extremities in terms of cardiovascular and peripheral vascular systems. You want to begin by an inspection of the precordium, and you will also be palpating the precordium, which will help you identify the point of maximum impulse. And remember, we said earlier that is located at the 5th intercostal space, mid-clavicular line. You want to begin with that because if you are then going to follow that up with an apical pulse, you would auscultate there. You want to make sure that you identify your landmarks, and you want to make sure that you listen in the specific locations for the heart sounds. For example, there are 5 locations that you listen to listen to the heart valves: the aortic, pulmonic, tricuspid and mitral areas, and Erb's point. Each of those areas is where you can hear certain type phase of the cardiac cycle best. You want to make sure that when you're listening to the heart, you can discern between S1 and S2, where S1 is loudest, where S2 is loudest. You want to be listening for any extra heart sounds, such as S3 and S4, which generally are abnormal findings. S3 can be normal in children. You want to assess for any additional sounds, soft, usually musical sounds, which are known as murmurs, that are sort of present over and above the heart sounds, and try to identify which phase of the cardiac cycle those murmurs fall within. Are they a systolic murmur or a diastolic murmur? All diastolic murmurs are pathologic. Systolic murmurs can be normal or pathologic. When you are palpating for the cardiovascular system, you're going to be feeling the temperature of the skin. You're going to be noticing how well perfused the skin is by doing capillary refill. You're going to be palpating for the pulses in the various locations. Here on the left of the slide, the brachial pulse is being palpated, and there is an examination of the feet. You do not use your thumb to assess for a pulse, so they cannot be measuring a pedal pulse in this picture. They are probably looking for edema. The left side of the slide, the nurse is palpating for a popliteal pulse behind the knee and a posterior tibial pulse in the foot. Here, the nurse is assessing the dorsalis pedis pulse. Again, auscultating the heart is the last skill that we use. We begin with inspection, we move to palpation, and we end with auscultation, except for the abdominal exam. And when we do an abdominal exam, we begin with auscultation. But for every other body system, auscultation comes at the end. Here, the examiner is listening for the apical pulse because they are at the fifth intercostal space, midclavicular line. Here are the auscultation landmarks that I mentioned a few minutes ago. You have the base of the heart, which is number 1 and 2, the right base and the left base of the heart. The third intercostal space, so the space that is numbered number 1 is the best place for you to listen to the aortic valve closure. Number 2 is where you can hear the pulmonic valve close. Number 3 is where you can hear the tricuspid valve close. Number 4 is Erb's point, where you can hear the valves equally. And number 5 is the point of maximum impulse. Here is another picture which demonstrates the locations of the various heart sounds. So at the right base is where you can hear the aortic valve. The left base is the pulmonic valve. Below that is Erb's point, where you can hear all valves equally. The tricuspid area is just to the left of the sternal border at the fourth intercostal space. And the point of maximum impulse, also known as the mitral area, is at the fifth intercostal space, midclavicular line. Auscultation is the most important technique utilized in cardiovascular assessment. And that's the end of the slide presentation for this week. If you have any questions, feel free to contact me, and good luck on your Shadow Health module this week.